going to tell you a little bit about what's going on today. I'm glad you're here because this is really, really a timely lecture. Just on my own, currently we have 4 friends fighting brutal types of cancer. And I'm sure among all of you, there's some friend or some family member that has the same problem.
Really?
So we've been gaining on cancer for a long time, and there are many tried and true therapies and methods. But in addition, now there's a new field. Some people call it precision oncology, and it encompasses what Dr. Cohen is going to talk about today. I just want to tell you that we're making the inroads of cancer because of the dedicated scientists and doctors who are doing this. That's why we have to support this research. And Dr. Cohen, I want to tell you, he's a giant in the field. So you're going to hear things from the horse's mouth. We're so lucky to have you. I'll tell you more about it.
I think you're up. I think you're up.
He's a board member of the Morris Cancer Center of UCSD and a longtime group of 12 members.
We really are very fortunate to have Ezra here today. He's the chief of the Division of Hematology Oncology and the co-director of the San Diego Center for Precision Immunotherapy at UC San Diego Health. He's a physician scientist, and he led an independently funded lab interested in mechanisms of action of novel therapeutics. He has made major contributions to targeted and immunotherapy. He's Associate Director for Translational Science and leader of the Tumor Therapeutics Research Program at Morris Cancer Center. He brings his expertise and preeminent reputation in head and neck cancer and research and patient care to solid tumor therapeutics. He completed his residencies in family medicine at the University of Toronto and in internal medicine at Albert Einstein College of Medicine. He completed a hematology oncology fellowship at the University of Chicago, where he was named chief fellow. Prior to his arrival in San Diego, Ezra was co-director of the Head and Neck Cancer Program, Associate Director for Education and Program Director for Hematology Oncology Fellowship at University of Chicago Comprehensive Cancer Center. I'm so delighted to welcome my friend, Dr. Ezra Cohen.
Thanks, Steve. Actually, I'm going to, bear with me, I'm going to try to turn this on. Does this work? Oh, it works. Nice. Do I have to turn this off?
Yes.
Perfect. Okay. You can hear me? Yes. All right. Terrific. Terrific. Thank you. Thanks for the invitation, and thanks for coming today. I chose a purposely provocative title because I thought it would draw more people in. So hopefully it worked. But what I will tell you for about the next 40 to 45 minutes is what is going on in oncology and how things are changing. And I'm going to focus on immunotherapy. For those of you who aren't intimately familiar with what's going on with cancer research, you may possibly not have heard of immunotherapy, although it's certainly gotten into the lay press quite a bit. Front page articles across the nation, on television as well. And for those of you who are more attuned or in tune with oncology research, you'll know that this is really changing not only the way we treat patients, but even really the way we view cancer. And that was the purpose of the title, because we're beginning to think that we can cure patients that in the past we never imagined possible. And I'm going to show you some examples of that, and I'm going to show you the directions that we're going in. This is the history of cancer treatment in one slide. It, of course, started with surgical procedures to try and take out cancers. Those have been in existence and refined for hundreds of years. For decades, we've had radiation therapy, which is essentially the application of a large dose of energy to a specific part of the body. In this case, it would be the tumor, in the hopes that the radiation would kill the cancer. And then for a few to several decades, we've had chemotherapy, which of course is the administration of a poison, a toxin, to the DNA, with the idea that because cancer cells proliferate at a much higher rate than normal cells, we have an advantage in killing cancer cells if we poison their DNA. But of course, the problem is that we poison normal cells as well, and that's why blood counts go down, that's why people lose their hair. Not such a bad look, but some people don't appreciate it. What can I say? But you get my point. The past has been really non-specific therapy using the best tools that we had. And the question that has been around for a long time, actually for, believe it or not, about 100 years, is that can the immune system help control cancer? And I say for over 100 years because the first experiments with immunotherapy, believe it or not, were done by a surgeon in New York at Memorial Sloan Kettering who made a very simple observation in a patient who had a sarcoma, and this patient happened to get a very serious infection, a skin infection. Now, this was before antibiotics existed, so these infections often would result in the patient's death. Well, this patient didn't die. They got very, very sick, but they didn't die. They got over the infection, and their cancer went away. And Cooley was his name, Dr. Cooley. He somehow connected this response that the cancer had to the fact that the patient got over the infection and hypothesized that it must have been the immune system that did this. In fact, he created something called Cooley's toxin, some of you may have heard of it, which was essentially administering live bacteria to patients, so giving them an infection. And believe it or not, that was FDA approved until the early 60s in this country. You can no longer get that for probably obvious reasons. But the answer, we think, is yes, and I'll show you why we think that in just a few minutes. But we have to understand something about the immune system, in that it wasn't designed to fight cancer. The immune system is designed to fight pathogens, to protect us from viruses and from bacteria. And if you remember that throughout this talk, you'll understand why it's been a challenge to manipulate the immune system, and why now, with the knowledge that we have, we're beginning to take advantage of those physiologic processes. And that's really what we're doing within the scope of immunotherapy, is we're taking a normal response that the immune system has and trying to divert it or augment it in an effort to destroy cancer cells. So let's do immunotherapy or immunology 101. Let me just give you a very quick primer on what the immune system is, because it's going to be relevant to what we're going to talk about towards the end of the talk. And essentially, the immune system consists of a defense that has an innate arm, that's what we call it, and an adaptive arm. And you'll see why we call those two what we do in just a minute. The innate arm is evolutionarily preserved. It is present in small mammals, it is present in insects, it is present in worms. Many species across the evolutionary tree will have an innate immune system. And what the innate immune system really is there to do is that first line of defense, that early alarm system to tell the body that, hey, something is wrong here. It is always on, it responds immediately, and it is that first line of defense against, remember, viruses or bacteria. That's what the immune system is designed to do. Now, the adaptive immune system is the part that, as the name implies, adapts to whatever the pathogen is or whatever the insult is. And for those of you who have ever had a vaccination, anybody ever had the measles vaccine or anything like that? Excuse me, the flu vaccine. We are utilizing the adaptive part of the immune system to really try to form a response to, in the case of vaccine, what we're vaccinating, or if you've ever had a cold or a virus, you're never going to get that again because of the adaptive immune system. And what the adaptive immune system does is it learns. It understands what the pathogen is, and it mounts a very specific response against any cell that is infected by that pathogen. And that really is the beauty, one of the beautiful things about the immune system is that it is cellular specific. The immune system can find a cell that has something wrong with it, and it can destroy only that cell and leave all the rest of the normal cells around it completely alone. And the other nice thing about the adaptive immune system is that it remembers. It has memory. Part of the process is that some of the T cells that respond to an infection turn into what we call memory T cells. And they live within us for the rest of our lives. So that if we see this virus again, we don't get sick. The memory T cells proliferate, they get their signal, and they eliminate the viral infection before it ever becomes serious. So that's Immunology 101. Why do we care? Why are we excited? And I'll show you a couple of examples of why this is really changing the field. This is the first, and this is the way, as a a doctor who treats patients, this is the way I look at it. This is called the Kaplan-Meier curve. And what it's meant to illustrate on the x-axis is time, and on the y-axis is survival. So if you take a typical group of advanced cancer patients and you treat them with the therapy that I showed you on the first slide, unfortunately, what happens over time is that the curve goes to zero. Patients with metastatic disease right now, I'm going to show you some exceptions to that, but what we've come to understand is that that is not a survivable cancer. The curve goes to zero. What we've been able to do as we learn more and more about the genetics of cancer is we've been able to improve standard therapy by using targeted agents that may target a specific gene or a specific alteration, and we've had great success, there's no doubt about it. And what we've been able to do is we've been able to shift that curve so that the average patient lives longer, but the curve goes to zero. The reason we're excited about immunotherapy is that although for most cancers we haven't been able to shift how well the average patient does, what we've been able to do is create what we call a tail on the curve. It doesn't go to zero. Now, for most solid tumors, that goes to 10%, maybe 20%. For melanoma, believe it or not, it's 50%, 50. We are now, if you have metastatic melanoma, you have a 50% chance of surviving 5 years. That would have been unheard of even just a few years ago. For lung cancer, with immunotherapy, it's about 20%. For head and neck cancer, the disease I treat mostly, it's about 15%. The point is, it's not zero. And if we can do it for one person, we need to learn how to do it for everybody. And that is the other thing that we see in this curve, is that there's a lot of room for improvement. And what I'll show you at the end of the talk, or the second half of the talk, is how we're trying to do that at UCSD. Let me give you the other example and really take it into a real-life patient and a real-life situation. This is a gentleman who presented to us, actually presented initially to an institute in Los Angeles, 55-year-old gentleman at the time who had HPV-positive squamous cell carcinoma of the head and neck. For those of you who aren't intimately familiar with head and neck cancer, we now recognize this virus called human papillomavirus, HPV, as a causative agent for these types of cancers. Now, I would say in our clinic, about almost half the patients have head and neck cancer related to HPV. Incidentally, HPV is a totally preventable cancer if we get immunized, so I'd encourage you to immunize your children or your grandchildren. We can talk about that if there's interest. But irrespective, this gentleman presented with an HPV-positive head and neck cancer. And he was treated with standard therapy, radiation, and a drug called cetuximab. And he was treated with curative intent. In fact, in a patient like this, we would expect to cure the disease anywhere from 70 to 90% of the time with standard chemotherapy and radiation. Now, for those of you who aren't used to looking at PET scans, orange is bad. So what we can see in this gentleman, when his disease came to the clinic, is he had a large tumor in his base of tongue, and he had a lymph node over to the side. Orange and red are bad on a PET scan. So he was treated, no interruptions, he did fine with therapy, and then 12 weeks after we complete that treatment, we routinely get another PET scan with the expectation that we would see the disease is gone. Remember, he was being treated for cure. Well, the PET scan after he finished not only didn't show that the disease was gone, but the disease is actually worse. You can see that now it occupies his entire tongue, and both sides of his neck have lymph nodes. This is a disaster. The only therapy that we have for this is surgery, which would require a total glossectomy and a total pharyngectomy. We would have to take out his tongue, and we'd have to take out his throat. And even with that surgery, he only has a 10% chance of survival. Well, he was told that, he was given those odds, and he said, that's unacceptable. You'll see why having a voice for him is critical to his day-to-day activities in just a minute. And he said, there's got to be another way. He talked to his doctor up in Los Angeles, and who I know very well, and he said, well, you know, they're doing some innovative things with immunotherapy down at UCSD. Why don't I have you see Dr. Cohen and see if there's anything that they can offer down there? He came down, we saw him, and we said, look, we're seeing some very interesting results with immunotherapy, especially on a clinical trial that involves a combination of a drug called pembrolizumab and another drug called epacadostat. You don't need to remember that, there's no test at the end. But the point is that together they seem to be able to activate the immune system in some people, do that very well, and we're seeing some very nice responses already. He was interested. He had really nothing to lose because he wasn't going to have the surgery. And we said, well, let's put you on this study and let's see what happens. Well, about 2 weeks after he got on the trial, he gave me a call. He said, Dr. Cohen, something's going wrong. My pain has dramatically increased. I can't swallow anymore. And the tumor just feels like it's growing. It's getting bigger. I said, Ricky, wait a second. That doesn't make sense to me, that in 2 weeks the cancer would have grown this much. I'm going to put you on some pain medicine. You can go on a fully liquid diet. You can maintain all your nutrition. And if you stop breathing, call 911. So that's a joke. Thank you for laughing, ladies. About 2 weeks after that conversation, he gave me a call, maybe 3 weeks after. And he said, Dr. Cohen, I haven't taken pain medicine in 4 days. I'm swallowing better now than I have in over a year. And I think I just coughed up my tumor. And you know what? I think he did. Because this was the PET scan 9 weeks into the study. And you can see that there's just a little circle of orange, or yellow in this case, that's left. His tumor was more than 90% gone. We did a PET scan 9 weeks after that, and his tumor is completely gone. And for those of you in the front of the room, you may notice that the date on these scans is 2016. He is now 4 years out. His name is Ricky Rocket. How many remember a band called Poison? His name is Ricky Rocket. He's now 4 years. He has no cancer. And by the way, this is my best cited paper in People magazine. So I'm not kidding. And Poison has gone on tour 2 times since his diagnosis of recurrent squamous cell carcinoma of the head and neck. By all rights, he should be dead. And not only is he very much alive, but he has a normal life. He's functioning normally, and he's doing everything he wants. For those of you who are interested, Poison is going on tour again this summer. Amy, July 23rd? They're in San Diego? Okay.
Does he sing? We're all going.
He does, although probably not on the tracks that they're going to play. He's the drummer for Poison. He started Poison. Well, that's a great story. What our challenge, of course, is to turn that single story, and we now are seeing patients like this actually on a fairly regular basis. We now have patients with lung cancer that are 6, 7 years out. I talked to you about melanoma, now 9, 10 years out, cancer-free, who used to have metastatic disease. But we don't want to turn this into an anecdote here or there. We want to turn this into the regular story. We want to be doing this 50% of the time, 80% of the time, and then eventually 100% of the time. So how do we get there? How do we learn how to do that? And to do that, let's talk about how the immune system and cancer interact. Well, in order to do that, let me take you through a stepwise process of what happens and how the immune system recognizes a cancer. The first thing that has to happen, just like any physiologic process that the immune system can detect, like a viral infection, the first thing that has to happen is antigens have to be released. Antigens are what the immune system recognizes. Those antigens have to go to a specialized cell called an antigen-presenting cell. Mostly they're dendritic cells. And those cells have to present that antigen on their surface. Those are the teachers of the immune system. They teach the other cells of the immune system how to respond. We call that priming and activation. So now those antigen-presenting cells are teaching T cells, they're priming the T cells on what they need to do and how they need to do it. Well, those T cells now, they have the information, they have the code, and they have to go to the cancer. So that's called trafficking. They have to get into the cancer, infiltration. They have to recognize the specific cancer cell that they've been educated to destroy. And once they do that, they kill the cancer cell and only the cancer cell. Well, that's a complicated process, as you can imagine. A lot of things can go wrong along the way, and a lot of things have to go right along the way. Well, we've learned that there are factors that influence this process. And lo and behold, we can manipulate those factors. Now, these are not mutations. These are not alterations. These are normally occurring physiologic processes, but we can manipulate them. There are ones that stimulate the immune system, and there are ones that inhibit the immune system. And in fact, we've had the most success with the red ones, the ones that inhibit the immune system. And Ricky Rocket was on, one of the drugs that he was on was a PD-1 inhibitor or PD-1 antibody that allows the T cells to get activated by releasing a very important brake on the system. Well, we've had a lot of success with immunotherapy, and this is the list of cancers this is actually even a year old, so this is December 2018. The list continues to grow. This is the list of cancers where immunotherapy has approval. And you can see that it's quite extensive. It's not something I expect you to read. The point of the slide is that it's growing. It's now across the board in almost every cancer we see. I told you I treat head and neck cancer, so I'll give you the example in the disease that I know best, and that is a trial that we ran comparing a drug called pembrolizumab, so this is an immunotherapy, versus standard of care in patients with head and neck cancer who were already refractory to chemotherapy. We had never had an approval in second-line metastatic head and neck cancer. Despite multiple attempts, no drug had ever shown a survival benefit. And then we tried immunotherapy by blocking just a single receptor in the immune system. What we see is an improvement in survival over standard therapy. The green arm represents immunotherapy. Interestingly, we've learned along the way that for drugs like this, pembrolizumab, we have a very good biomarker called PD-L1 that can tell us which patients are more likely to benefit. Keep that thought in mind because it's going to be germane to the end of the talk. More likely to benefit, more likely to respond. But we have to do better. It's not enough to have 10 or 15% of our patients surviving long term. It's great, it's better than zero, but it's not enough. And so for the rest of the time, what I'll talk to you about is directions that we're undertaking to try and improve where we are with immunotherapy. And one of the first things I want to mention is that there are many organizations out there. This organization in particular, Immunotherapy Foundation, I do want to spend a moment to tell you about because first of all, it's a San Diego organization. Secondly, they're committed to developing immune immune therapies and immune responses to cancer. And thirdly, they funded much of the work that you're going to see, especially at the beginning of the next part of the talk. So thank you to Immunotherapy Foundation. And I think it's worthwhile looking them up and seeing more of what they do, because they've really been a wonderful partner through this process. Having said that, let me talk to you about one of the directions that we're taking, and that's personalized cancer vaccines. In order to do that, let me give you a bit of background. What you've probably gleaned from the talk so far is that the immune system is very specific. It can identify a single cell that has a viral infection. It can destroy that cell. The immune system, though, is different between all of us. You can get the same viral infection as the person next to you. You may have a completely different immune response to that viral infection. The other thing that we've come to understand about cancer is that every cancer is different. We may see 2 patients in our breast cancer clinic that are labeled as breast cancer. On paper, they may look exactly the same. Under the microscope, their cancers may look exactly the same. But when we look at those cancers at a molecular level, we've come to understand that they're different. No 2 cancers actually have the same molecular profile. So about 5 years ago, my collaborator and I, Steven Schoenberger, sat down and we were given a challenge by Immunotherapy Foundation to take the next big step in cancer treatment. And so, recognizing those 2 facts, we thought it didn't make sense to us to develop therapies that were going to be applied across the board to tens or hundreds of thousands of cancer patients. We've had a lot of success doing that. But we hypothesized that if we were going to take the big steps forward and recognize that everybody's cancer is different and everybody's immune system is different, we had to develop therapies that brought those 2 facts together. And what that meant was we had to develop therapies for one person at a time, because everybody is different. And that's when we undertook the personalized cancer vaccine project. What we had to do first was identify mutations in each patient's tumor that was recognized by their own T cells. And we called those neoantigens. Antigen is what the immune system recognizes, neo is new. The second thing we had to do was develop an effective vaccination strategy to direct these neoantigen-specific T cells to eradicate the cancer. So what we recognized was that every person that we profiled, believe it or not, had T cells in their system that recognized their cancer. The problem was that those T cells weren't being turned on, at least not effectively enough to destroy the tumor. And so that's where the vaccination came in. Here's the process that we developed. It took about 5 years to do this. So we take the patient, we get a tumor sample, we sequence that tumor, so we understand what the mutations are across the entire tumor. We then take that information and we put it into a bioinformatic analysis that doesn't guess at what the relevant mutations are, but what we've developed is an algorithm that we've learned along the way what the most immunogenic mutations would be. That is what the immune system is most likely to respond to. We then create peptides, because peptides are what the immune system recognizes. We create peptides out of those mutations. We get about 50 cc's of the patient's blood. We isolate their T cells, and we put those 2 things together, and we ask a very simple question. What is that person's immune system responding to in their cancer? And that gives us, we co-culture, that gives us verified neoantigens. And by the way, this methodology has been proven to be about 10 times more reliable. It gives us about 10 times more information than existing in silico or computational algorithms. And at that number, it's not perfect. We don't get every single neoantigen, but we get enough neoantigens that we can now begin to think of turning that information into a therapy, and that therapy becomes a personalized cancer vaccine. And if you're following what I'm saying, that therapy that we create applies to one person on Earth. and only that person, because everybody's cancer is different and everybody's immune system is different. Well, we've done this across a whole host of tumors. In fact, every patient that we've profiled, we've been able to find neoantigens. And then about a year ago, we treated our first patient. Her name is Tamara Strauss. Some of you might know her. There I am about to give her an injection. Don't tell her this, but I actually had to YouTube how to give a subcutaneous injection, because I hadn't done it in 20 years. So she doesn't know that. So if you meet her or if you know her, no, don't tell her. Do not tell her. So, but we were lucky enough to make the front page of the Union Tribune. She had the vaccine, as you can see from the date, in 2018. She did very well. She went about 9 months with no growth of her cancer. Unfortunately, eventually the cancer began to grow. But one thing that we did see in her cancer, which was pretty profound, we do biopsies before the vaccine. I told you because that's how we derive the neoantigens. And then we do a biopsy after the vaccine is administered. And what we saw in that biopsy after the vaccine was that the 2 mutations that we immunized her against had disappeared from her cancer, telling us that we were on the right track. We had given her a vaccine, and her immune system was able to eliminate the mutations that her immune system was vaccinated against. Patient number 4 on the vaccine was even more profound. I'm walking down the hallway back to my office, and 2 doors down is a colleague of mine, Tina Sacco. And her door is open. She hears me walking by, and she goes, "Ezra, come on in. You're not going to believe this." And she showed me these 2 scans. And this is patient number 4 on the vaccine. And what we saw, this is a patient who was 43 years old, 4 kids, unable to work, barely able to leave his house, had been refractory to 4 lines of chemotherapy in the past, got on the vaccine. And what this is meant to illustrate, for those of you who aren't used to looking at CT scans, is the red is tumor, that's right next to his spine. In March, in June, that's almost completely gone, telling us that we're on the right track. This is another slice of his chest. You can see the tumors circled in red, and you can see that they're gone. He was able to go back to work. He was able to take his kids to the beach and live a fairly normal life after 3 months of the vaccine, telling us that we're on the right track. This is the current iteration of the vaccine schedule. We've learned along the way. We've learned from what we're doing in the laboratory. We've learned from what we're doing in patients. And now we're giving the vaccine as a boost up front, so 3 quick doses, and then more doses on the back end. And the first 2 patients actually were just treated. The 3rd patient is about to be treated, and hopefully we'll continue to see positive results. So that's the personalized cancer vaccine story. Let me move to another story, and that's natural killer cells, or immune pluripotent stem cells that are actually turned into natural killer cells. So these stem cells, we all have them in our body. And believe it or not, we can program these stem cells by growing them in the right environment into whatever we want. In this case, we can program them to be a powerful cell of the immune system called a natural killer cell. And the nice thing about natural killer cells is, as opposed to T cells, that I told you the T cells need to recognize their peptide, they need to recognize their antigen. Well, natural killer cells don't need to do that. They actually can recognize cells that carry mutations without that specificity that a T cell requires. So it gives us another weapon that we can use in the immune system. Well, Dan Kaufman and his colleagues have worked out a way to turn these pluripotent stem cells into natural killer cells very efficiently, very effectively, and he's turned this into a number of clinical trials that are ongoing right now at Moores Cancer Center in both solid and liquid tumors. And this is the first patient that was treated on the natural killer cell product that was derived right here, actually. It was created right here in the cell therapy laboratory. Second last story is another homegrown effort called sermtuzumab. Serumtuzumab is an antibody, so again, utilizing a part of the immune system, that recognizes a receptor called ROR1. And ROR1, discovered or developed by Tom Kipps at UCSD, because it was present on every single cell of the cancer that he was treating, and that was chronic lymphocytic leukemia, or CLL. It turns out that ROR1 is present on cancer stem cells almost across the board in almost every solid tumor and heme malignancy that we profile. And so ROR1 now becomes an attractive target for things like antibodies or cellular products. Well, Tom turned this into a therapy in, again, the disease that he treats, that's chronic lymphocytic leukemia, in patients, and saw some very interesting results with serumtuzumab alone, demonstrating that patients appear to do better than what we would expect, or what we call historical controls. We've now converted this into a trial in breast cancer that's ongoing right now in combination with a chemotherapy drug called paclitaxel. And just about to start, led by Raina McKay, is a trial in prostate cancer combining it with a drug called docetaxel. And so we think that serumtuzumab may be able to target this important component of a cancer, that is the cancer stem cells, that tend to be resistant to chemotherapy, while the chemotherapy will eliminate the other parts of the tumor. And of course, these trials are ongoing, and we'll see results hopefully in the near term. And I pressed something that is not allowing me to advance. There we go. Lastly, I want to tell you another direction that we're going, and that's led by Shumei Kato. And getting back to this idea of conventional immunotherapy, the PD-1, the PD-L1s. This is the drug that Ricky Rocket was on. This is the drug from the curves that I showed you. This has been probably the most successful immunotherapy that we've ever had, targeting PD-1 or PD-L1. The problem is that we don't have enough patients to test all of the therapies that we're developing. And so there just aren't enough cancer patients, fortunately, in existence that would allow us to test all the ideas. So we have to begin thinking a little bit more intelligently and ask ourselves, well, which cancer patients are going to benefit from which therapies? We need to begin to make that connection, otherwise we're shooting in the dark. And that's exactly what Dr. Cato's group has done. And getting back to our ability to profile cancers, remembering that every cancer is different, we can look now at a genetic and an immune profile of a cancer, and we can begin to decide what immunotherapy they should actually go on, which immunotherapy are they most likely to benefit from. And that's the type of work that Dr. Cato is developing. And in fact, we're doing that in the context of a new clinic that we created called the Precision Immunotherapy Clinic, that now takes patients, analyzes their tumors, and matches them to what we think is the most appropriate therapy. This just started in the fall and is continuing to grow. So I left enough time for questions. I'll leave you with a few thoughts that really the era of cancer immunotherapy is here. We're not going back. We're only getting better. Anti-PD-1 and PD-L1, so pembrolizumab, nivolumab, that list of drugs, has an established role now in multiple cancers. And in fact, checkpoint inhibitors, this ability to manipulate a physiologic process of the immune system, and other immune modulators are being tested now in every cancer, and we're continuing to see successes. Immunotherapy can potentially cure patients even with metastatic disease. I showed you the example of Ricky Rocket, but he is not an N of one. He is not the solitary example. We have patients now, as I said, those numbers are growing, that are surviving years having been diagnosed with a terminal illness. But we have a lot of work to do. There are a lot of big questions in the field, and there's a lot more that we have to learn. This is a short list of them, but we really do want to get from 10 or 20% of patients to eventually 50, 80, and 100. And I believe we'll do it and I believe that we will do it in our generation, because we have the technology, we're working on getting the resources, and we have the science that's able to direct those resources to develop appropriate therapies to help us move forward. And the truth is, we have to do it. We owe it to the next generation to eliminate this disease, because we can do it. Thank you so much for the invitation. Thank you for your attention, and I'll be happy to take questions.
We thank you. And now, whoever has questions, will you be able to stay after the formal?
I can stay, yeah. As long as you feed me, I can stay.
If you don't
I'm kidding, by the way. You had your hand up first.
Great presentation. Do you see any kind of common denominator in these cancers with, say, the T cells not performing as they should? And so if the T cells were fed properly,
Yeah.
let's say through micronutrients or whatever, could that have prevented the cancer in the first place?
So I thought you were going to ask a different question. So it's an interesting question. Let me just rephrase it. Is there, in a cancer patient, is there something peculiar to T cells that is making them less effective? And if we could make them more effective, would we be able to prevent the cancer in the first place? Did I understand that correctly? Yeah. So the simple answer to the question is yes. So we definitely see that. The phenotype of T cells that are present in a tumor is usually one of what we call exhaustion. They're not actually exhausted, but that's just the term we use. They have markers on their surface that tell us that they're not, they've gone past their optimal level of activity, and they're sort of on the back end of that. We can turn that around. In fact, that's exactly what a PD-1 antibody does. It blocks an exhaustion marker. We think that we can use the same type of tools to actually prevent cancer. Because those T cells exist, as I told you, it's just a matter of appropriately activating them. And in fact, in the long term, one of the things that we're thinking about with the vaccine is exactly that, using that as a preventative strategy. So I think the answer is yes. It's going to take us a little bit of time to get there.
Thank you.
When you described the vaccine patient that made the front page.
We can't hear you.
I'll repeat the question.
You later said you used 2 peptides as antigens for her. Was that because those were the only 2 antigens that her cells responded to?
Yeah, so in the examples that I gave, we used, if I can rephrase, we used a limited number of peptides. And the question is that because that's what the immune system was telling us, or was there another factor that decided that number? It was another factor, a factor that we've since corrected because we've learned along the way. The first manufacturing company that we were working with could only put 5 peptides or 5 antigens in the vaccine. Now, for Ms. Strauss, there were actually only 3 neoantigens that we identified. So for her, that was fine. For other patients, we see many more than 5. In fact, we usually see somewhere in the range of 18 to 20 neoantigens. And again, we're not capturing the entire story, but that's how much we see in the assay that I showed you. And so we learned in mouse models that, and intuitively it makes sense, that the greater the valency, the number of antigens in a vaccine, the greater the efficacy we would have against that tumor. And so we decided to switch to a different manufacturer that can put 24 antigens into a vaccine. And that's exactly what we're doing now. That's the arm that I showed you. So I think it will be more effective if we do that. Sorry, I don't know the order, but I'll take it from different sides of the room. So I'll apologize if I don't get to you first. Sir.
I saw glioblastoma on your list.
Yeah.
I just had a nephew, 15-year-old, die of a DIPG, which is probably the worst
Yeah.
brain tumor of all. I'm just wondering if you've had any success with brain tumor.
Yeah. So it's interesting because when the dogma in GBM is that you can't find neoantigens. And we can talk about why that is, but there's different aspects of GBM biology that make it difficult. Well, that is not true. We've been able to identify neoantigens. We've been able to activate T cells against GBM. We have not treated a GBM patient on the vaccine for a number of reasons. But we are actually looking at a collaboration with Sharp to actually start a cohort of GBM patients. Because I think that they would benefit from this. And as you illustrated in your question, it's a devastating disease. Brain tumors are unfortunately almost universally fatal, and we definitely need to do something about that. Let me take one from this. I'll just take them from different sides of the room. So be patient with me. Keep raising your arms. I apologize.
I have two questions. One is, what's the difference between targeted chemotherapy and immunotherapy?
Okay.
And the second one is, how long does it take to develop an immunotherapy?
Okay. So what's the difference between targeted chemotherapy and targeted immunotherapy, and how long does it take to develop the latter? Okay. So really, when we talk about targeted anything, usually what we're talking about is the application of a drug to either a specific individual that we think is more likely to benefit, or is there something inherent in their cancer that would make them more likely to benefit from this drug. So when we talk about targeting, that's usually what we're talking about. When we talk about targeted agents that are not immunotherapy, we're usually talking about a drug that is specifically applied to in the presence of a mutation. The best example would be in lung cancer. We now recognize that about anywhere from 10 to 30% of lung cancers have a mutation in a gene called EGFR, or epidermal growth factor receptor. When we apply a specific inhibitor of that gene in patients who have that mutation, we see wonderful results. So that's targeted therapy. Targeted immunotherapy, or what we like to call precision immunotherapy, goes along the same concept. So if a cancer has a mutation, or if the immune system is responding in a certain way, we can choose the treatments that would most likely produce a benefit in that patient. Now, how long does immunotherapy take to develop? To put it into perspective, the drugs that are now most approved, immunotherapies, those receptors were discovered about 15 years ago. And in fact, the two individuals that discovered those receptors won the Nobel Prize this year. So it takes a while. It's not overnight. Yeah, I'll get you.
The question is, if you're already getting treatment at UCSD, how can you, oncology, urology, how can you volunteer for the clinical trials? And the second question is, how do you feel about the docetaxel? Most literature shows that it's very toxic to the liver, kidneys, and most research has shown that it weakens heart muscle.
Yeah, so two questions. So first, in terms of, let me make it general. In terms of participating in clinical trials, I would urge you and urge if you know anybody that has a cancer diagnosis, or anybody that's dealing with it in some way, I would urge you to talk to your physician, ask them about clinical trials. The sobering fact about clinical trial participation in this country is that only 3% of adults get onto a clinical trial. Clinical trials are the only way we move the field forward. It's the only way drugs get approved in this country. If we are going to make advances, we need more people to participate in clinical trials. So I would talk to your physician. I can give you my card if you want to talk to me. But go out and actively seek clinical trials. I think as a patient, not only do you have that right, but it benefits you. And it benefits you because there are now data that clearly demonstrate that patients on clinical trials live longer, even when you match for disease, their comorbidities, their performance status, all of those things. Even when you match for that, patients on clinical trials do better than patients who don't go on clinical trials. So it really behooves you to do that. In terms of docetaxel specifically, it's a drug that's been around for a while. It's a classic cytotoxic chemotherapy. It poisons cell replication. It can be well tolerated, and it's an extensively used drug. It's part of our regular tool set, if you will. Interestingly, what we're discovering about docetaxel and that group of drugs that we call taxanes is that they actually may have positive effects on the immune system. And that's one of the reasons that docetaxel was chosen in combination with cemtuzumab. So yes, it has side effects. There are negative things that it does, but it's also done a lot of positive things along the way. This side doesn't have a question? You're going to lose your opportunity. Okay. Okay, we'll go to the middle. All right.
So with typical chemotherapy, let's say a patient gets in remission just to find out that 5 years later they get the cancer back.
Yeah.
With immunotherapy, is it safe to say that they will never get it back because the smart T cells get even smarter?
Yeah, so you're giving this talk next time. All right. I did not plant that question. So the question was, with chemotherapy, despite the fact that it might work at the beginning, I'll rephrase a little bit, it might work at the beginning, and it may work quite well at the beginning, the cancer comes back. And for some patients, that risk of recurrence can be quite high. Would immunotherapy do something different? Is it possible that immunotherapy could keep the cancer from coming back? Did I understand your question? And the answer is we think so. We strongly believe that. And again, one of the reasons that we're interested in immunotherapy. And in fact, the next arm of the personalized vaccine is going to be exactly in that cohort that you described. Patients who have been treated for their cancer, when we do scans, we don't see evidence of their cancer, but we know that they have a high chance of the cancer coming back. And we think that actually is the setting where the vaccine may be most effective, because exactly what you said, we can activate the T cells, and the T cells circulate throughout the body, they remember, and if they ever see that signal of the cancer coming back, even in a solitary cell, that cell gets eliminated. So that's what we're most excited about. And we've already seen with some immunotherapies that can happen. Yes, ma'am.
All right, for patients who've gone through chemotherapy, everything's in regression, but the immune system has been severely depressed.
Yeah.
What role does IVIG play in boosting the
Yeah.
immune system to activate T cells? Can that ever
Yeah.
happen again?
So the question was, in patients who've gone through therapy and they may be immunosuppressed, is there a role for something called IVIG, or intravenous immunoglobulin, to help boost the immune system? Did I understand you correctly? Yeah. So IVIG represents really a component of the immune system. It's not the whole, it's not the entire immune system. And unfortunately, it's very difficult for us in patients who get, let's say, highly cytotoxic chemotherapy. Bone marrow transplant patients would be, the best example, to recapitulate the entire immune system. And for those patients, we just have to wait for it to come back naturally. IVIG is a useful product. In some ways, it can prevent some infections. It can boost, as I said, a part of the immune system, but by no means is it the entire immune system. Sometimes we do use it in patients who are immunosuppressed. So it's a good tool. It's not everything. Okay, maybe just a couple more. This side of the room is you had your hand up a few times in the blue jacket.
Do you do immunotherapy and targeted therapy at the same time?
We do. So do we do immunotherapy and targeted therapy at the same time? And interestingly enough, what we're learning is that they can actually enhance each other's activity. We don't fully understand it in every case, but in many cases, what we've come to understand that targeted therapy can do a few positive things for the immune system. It can liberate antigens. Remember, that's where the whole process starts, that antigen release. It can actually improve the function of T cells, and in some cases, help T cells to get to the tumor. And in other cases, it can actually suppress or eliminate immunosuppressive elements of a tumor biology. And so there are now a number of targeted therapies, more than a few targeted therapies that are being combined with immunotherapy with a recognition that they enhance each other's effect. So definitely. Maybe a couple more questions.
Could you talk a little bit about precision immunotherapy clinic?
Yeah, sure.
Who gets seen age-wise?
Yeah, so the question was about the precision immunotherapy clinic. We would see anybody. It doesn't matter the age, doesn't matter their background, doesn't matter the type of cancer. And the idea is that, again, if we can appropriately profile what's going on with the immune system and the cancer, we may be able to direct more effective therapies. But it's really open to any cancer patient.
And where is it?
Oh, I should say, it's meant for cancer patients who have exhausted standard of care. So it really is not meant at this point to replace standard therapy. If there's a standard therapy for an individual's cancer, they should still get that. I mean, that has been proven, in large trials to be effective, to improve survival. We don't mean to supplant that. But for patients where standard of care is no longer working, it would be an appropriate outlet. It's at the Moores Cancer Center. Yeah. And I think I had the number in that slide. I can put the slide back up. Maybe one more question. Okay, pressure is on.
Okay, if a patient has autoimmune issues, how does this interact with that?
Good question. Good way to end. The number's way too small to see. All right, we'll give you the number. Or you can Google it, yeah. So what about autoimmune diseases? And that's a challenge for us because if you followed what I was saying, right now immunotherapy tries to stimulate the immune system, but in a non-specific way. And if we stimulate the immune system against the cancer, we do run the risk of stimulating the immune system against normal tissue. In patients where that has already occurred, patients with autoimmune disorders, the risk is much higher to stimulate the immune system against normal tissue. So for many patients with autoimmune disorders, unfortunately right now, we don't have a way to tease that out. And they may not be good candidates for existing immunotherapy. Now, as we get more specific with immunotherapy, the personalized cancer vaccine, for instance, certain engineering in immune cells, CAR T cells, or even natural killer cells, as we begin to get more specific and directed, you can imagine a day where we can activate the immune system in a very specific way to go after only the cancer. And we will get there, but right now it's difficult to tease that out. I should say, incidentally, that in patients who get side effects from immunotherapy, and they are autoimmune side effects, inflammation in the lungs, the gut, the liver, those patients actually do better on immunotherapy, suggesting that when we can activate the immune system, we can do that against both the cancer and, unfortunately, sometimes against normal tissue. Did that answer your question? Okay.
Thank you.
Thank you. Thank you so much.